So the discs are jelly-like materials which basically run through the entire length of a spine, and as I call it, it's like a shock absorber. And within that shock absorber, which is your disc, contains collagen, and collagen attracts moisture. So 80% of our disc is made up of moisture. The loss of moisture in your 80s and 90s later on in life is an age-related process, but in certain individuals, that loss of moisture is genetically predisposed. So people as early as in their 20s, 30s, 40s, and so on can experience a loss of moisture within the disc, which goes unnoticed in the adult life. So a significant proportion of the population, anywhere between 25 to 40% in their 20s and 30s, will be walking around with an abnormal disc in their back which has lost moisture but has not produced any symptoms. So in those individuals, when they are genetically predisposed, they are susceptible to an event, and that event could be either they have taken up a new sporting activity or they have hurt their back in their gym, and as a result of that sort of certain activity, or in certain cases without any underlying sort of underlying situation, the disc can prolapse. And there are different terms, and I get that asked very often. Doctor, I've been told I've got a disc prolapse, but I thought it was slipped. And so these are different terminologies. So a slipped disc is generally a sort of a very broad nomenclature which is generally used, but in medically, the term which is used is called a disc prolapse or a herniated disc, where the jelly within the disc comes in contact with the nerve. And these are the bunch of nerves which come through the entire length of the spine, but predominantly in the lower back. They can irritate or press on the nerve and produce varying symptoms of what we term as sciatica, which is the nerve which goes down the leg and can range and can give you a range of symptoms. Those symptoms can range from pain going down in either of the legs, radiating all the way down to the foot. There can be associated change in the temperature. There can be pins and needles, tingling, and all of these are secondary to the pressure of the slip disc in the lower part of the back, pinching the nerve. So before we go into the surgical options, it is always helpful to understand what happens to a slip disc. And as I tell most of my patients who come and see me, is that if you have a cold, whatever you do about it, it's going to annoy you for 7 days. And the disc also follows. So what we term in the medical world is called a natural history of a condition. It's a natural history is that if you were to allow to run its course, what particular happens to a particular condition. And the slip disc, fortunately, has got some predictable factors within that. The most predictable factor we know is that when people initially start getting pain going down the leg, which we term as sciatic pain, if this is the first ever episode, between 40 to 60% of them will normally settle between 4 to 6 weeks, just on its own. And we'll come to some of the management, which would involve taking painkillers, keeping yourself active, but within reason, trying not to push yourself through pain, seeing a physiotherapist, that is usually helpful. You also need to appreciate the fact that you might have some variations in the pain. So on a good day, you might decide to push yourself a little bit too much, and you notice that 24 to 48 hours later, the inflammation builds up and the pain. So it's about listening to your body and giving it time, and that's why when you see your GP or your physio or your specialist, they might say, if you've seen them quite early on, they would give you a combination of taking painkillers like paracetamol and ibuprofen, allowing the pain to settle down over the next 4 to 6 weeks, which happens in a significant proportion of people. Unfortunately, what is unpredictable is that which individual might fall into that category. How do I know? Am I going to get better in 2 weeks? Am I going to get better in 6 weeks? Or will I be one of those people who might not get better? Unfortunately, there are no predictive factors for that. It is just a matter of giving it time. The other thing I normally get asked is, I'm so young, how come I got a slip disc? So slip disc occurs in 60% of the adult population between the age of 20 and 45. That's because the disc has got a lot of sort of has got less moisture, but still a lot of collagen and jelly, and that's why it's much more susceptible for it to slip. So having given it time, if the symptoms still do not settle, which is when most people would say in the presence of persistent symptoms beyond 2 to 4 weeks or between 4 and 6 weeks, that is when individuals will get referred to the spinal surgeon. And at that stage, you'll have a clinical assessment based on the symptoms which has been going on for the last few weeks. And we would then investigate this by getting an MRI scan. As we discussed previously, a significant proportion of our patients will settle down by keeping themselves active, taking painkillers as and when required, seeing a physiotherapist or a manual therapist, and things will settle down in nearly 60% of the individuals. An MRI scan is to confirm the slip disc and the location of the slip disc, and for us to clinically correlate that with your symptoms. Following that, in the presence of persistent pain, one of the options you might have is to consider a spinal injection, and that would be a steroid injection. Steroid acts like it's like a super neurophin. It's like taking 20 neurophins in your back at the same time. And what it does is it acts like an anti-inflammatory. So the jelly within the slip disc irritates the nerve. As it irritates the nerve, it produces inflammation. As the inflammation goes up, you have increased pain. So your variation in your pain is as a result of the inflammation going up and down. And so it's not uncommon to have variation within the first few weeks. So, and what the cortisone injection does is it decreases the inflammation. Because as the inflammation decreases, your pain then gets better with the injection. And what that injection then allows you to do is to give you a window of opportunity of 4 to 6 months as your pain is better, is for your body to allow that disc to heal itself. And that's how the rationale of injections. And most people, when they have pain beyond 4 to 6 weeks, for up to about 4 to 6 months, would consider injections. But obviously there are some some limitations as to which individual can have injections and who require an operation, which I'll cover in the next question. A lumbar disc operation, there are different techniques. And if you look at techniques, the techniques vary from using endoscopic techniques to keyhole, but the gold standard seems to be a keyhole technique, which is termed as a microdiscectomy, where we use a microscope with a small cut in the back to shape the slip disc. So the indications for the operations in most instances is persistent pain, which has lasted for beyond 4 to 6 months. And as you can imagine, 4 to 6 months with pain can seem a very, very long time. During that phase, most people have taken painkillers, they've adapted their lifestyle, they've had 1 or 2 injections within that period, and the interval between the injections can be between 4 to 6 weeks, and they've come to a stage where this is clearly influencing the quality of life. And that would involve persistent pain beyond 4 to 6 months in the persistence of your symptoms, where the surgeon would discuss surgical intervention on the basis that the slip disc is not healing and producing persistent pain. Lumbar disc operations are extremely common, done by spinal surgeons throughout the length and breadth of the world with good outcomes. What you can expect with an operation is some predictable factors. So the success rate with the operation is 85%. If you look at 100 patients who were to have an operation, 70% will be pain-free. A further 25% will have some residual pain, but significantly better. The chance of your symptoms remaining the same is 4%, and having a complication as a result of an operation is 1%. So overall, the benefits far outweigh the risk. The chance of the slip disc occurring again following an operation is 7% within 10 years, so it's quite small. And the recovery for this procedure is about 3 months, where after 3 months, a significant number of people will be able to go back to their hobbies and sporting activity. And that would be, and that's the question I normally get asked, is saying, well, it's really important for me to run. I enjoy going to the gym. Physically and mentally, that's important for me, doctor. And part of that process of the discussion about the the indication for the operation, but more importantly, the outcome as to whether we can allow these people to go back to what they were doing. And in a vast number of cases, predominantly most of them are able to go back to their hobbies and sporting activity. The risks with this surgery are extremely small. The risk of nerve damage is in the region of 1 in 800. You can have a leakage of spinal fluid, which is a covering of the nerve. If the surgeon damages that, the risk of that is less than 3%. The risk of infection with any intervention and the general risk of any surgery. But overall, if you look at the risk-benefit ratio, the benefits far outweigh the risk of this operation. So a lumbar disc operation can take anywhere between 60 to 90 minutes. It's usually an overnight stay, but obviously with how things are moving forward, we are looking at getting these operations done as a day case procedure. So in some institutes, we have the capacity to do that as well. But usually it's an overnight stay in hospital. The following day, the physiotherapist will give you a set of exercises. You're up and about, you don't need a brace or a belt for your lower back, and you're able to go home unaided, independently walking, having done the stairs and independently being able to get off the bed with adequate analgesics. The wound normally takes 10 days for it to heal. We bring you back to the clinic to have a look at your wound, or we can send you back to your GP to have a look at that if it's much more convenient and much more closer. The initial 4 to 6 weeks is just recovering from an operation where you're able to walk around, do some gentle exercises, hopefully without the pain which has been there in your leg, which can in certain instances be pretty spontaneous after the operation. At 6 weeks, you're able to get back to swimming. Driving your car could be anywhere between 2 to 4 weeks. Getting back to work, obviously quite important for a significant number of people. Obviously, part of our job is to bespoke, because some people's work might involve a little bit more sort of heavy activity. Some might have to travel a lot. Travel is usually between 4 to 6 weeks, purely because of not just the operation, but because of the risk involved with getting clots in your leg, especially if it's a long haul flight. But generally, most people recover very well anywhere between 4 to 6 weeks. Before you can get back to any impact or sporting activities, that would be 3 months, which is 12 weeks. And between 6 and 12 weeks, part of our conditioning and rehab program would involve bespoking it to your requirements as to what your hobbies and sporting activities are. In people who have a lumbar herniated disc, if the size of the disc is extremely large, it can press on the bunch of nerves in the lower part of your back, which is responsible for the function, but also responsible for the sensation and bowel and bladder function. So these are exceptions where you should not wait, but go to an A&E as soon as possible. This would involve symptoms where you have pain going down one or both legs, where you have associated symptoms of your bladder, where you're not being able to control the bladder, or you feel that your bladder is normally weak than what you normally function at. If you feel that when you've been to the toilet and when you wipe your back passage, there's a decreased sensation or numbness. So in situations like this, I would strongly suggest that you go to the A&E as soon as possible, where they would do an urgent reassessment of you and request an urgent MRI scan, because this is a time-dependent condition. And people in this situation, once it's confirmed that they have got a large slip disc pressing on the bunch of nerves, require surgical intervention, i.e. operation, as soon as possible to preserve their function. In a similar scenario, if you have woken up with pain, but your bladder function is normal, the sensation is normal, but you feel that you have lost some function in your foot, where you're not able to bring your foot up towards you or push it down, then we would recommend that you get seen sooner rather than later, i.e. within 1 to 2 weeks, rather than wait for 4 to 6 weeks, as we mentioned earlier in the video.